Good morning, everyone. Heartfelt thanks for having chosen to attend our session. We have a great team of speakers. We've been doing this course in many conferences before. We've done it in APAO, AIOS, TNOA. Every time we do it, there are a lot of updates and new information from our speakers. I'm sure there'll be lots of take-home and practical pointers from this session. To begin with, I will be talking on K yesterday and today. Well, evolution is the key. We've been evolving. We had live conferences, virtual, and we are back to live, thanks to DreamCon. K also has been evolving. Well, this was an interesting article which I went through, which says that there's been a steady increase in usage of toric implants. A difference in K of just 0.2 causes an IOL power difference of about 0.5 diopter. So, K is the king. Going back in history, heritage, how this keratometry came into existence was because of this great man, Van Helmholtz. His keratometer is available even today to visit at the university in Netherlands. However, practically usable keratometer was devised by Dr. Jawal and Shiatz, based on the principle of biprisms and doubling principles. This was used to negate eye movements so that we can get a good keratometry value. However, this K had certain limitations. Mainly, it measured only the central cornea, and the peripheral and paracentral cornea was ignored. And we tend to ignore minimum irregular astigmatism if present. This was believed to be absolutely terrific till 7 to 8 years back, until Dr. Douglas Koch, with this landmark trial, opened a Pandora's box talking about posterior corneal astigmatism. This made us understand fallacies of keratometers. Well, when I was preparing for this trial, I was a little confused. Who actually opened the Pandora's box? Well, as early as 1890, Dr. Jawal spoke of the relationship between the posterior cornea and the amount of astigmatism that we get. However, we kind of ignored this for more than 100 years. I feel mainly because we didn't have equipments to perfectly calculate the curvature from the posterior surface of the cornea, and we kept the Pandora's box closed. However, this was reopened in December 2013 by this landmark trial where Dr. Douglas Koch and co. said most of our patients with the rule astigmatism was overrated by almost all equipments available then, for which, for toric implants, Baylor came out with the nomogram to correct it. And then there were lots and lots of other myths also. During my PG days, there was a fact, or there was a belief, that when we incise the cornea, there is some amount of flattening happened. However, it is history now. Incision need not cause flattening. Incision can cause flattening on axis as well as off axis, courtesy Dr. Warren Hill. He spoke on the concept of a centroid value. So in principle, if you're not aware of your surgical induced astigmatism, if you're making temporal clear corneal incision less than 3 mm, you can use your SIA as 0.2. And when this was applied to calculators, we found that there was far better accuracy and much more better results when the SIA was changed from 0.5 or 0.3 to 0.12. However, now with regards to K, all interest goes to Dr. Graham Barrett. He spoke on the concept of true K and an unbelievable calculation of the predicted posterior corneal astigmatism. He gives this for free to all of us. This is available with the ACRS and the APACRS website. You can go click on this K calculator. You will be asked to enter in data from 3 different keratometers, maybe from the manual K, IOL master, or from the pentacam or any topographer. And then it gives an integrated K as a median value, which can be entered. And what is surprising or very interesting to note is that Dr. Barrett's predicted posterior corneal astigmatism is far more accurate than the actual measurement done with the current generation swept source-based biometers. However, measuring the true K is very important for post-refractive surgery eyes. We have the concept of telecentric keratometry in certain equipments, mainly the IOL 700, where even if the patient's head is decentered a little, the equipment takes that into consideration and gives us fairly accurate values. The measurement of posterior cornea by this device is, it gets the information and makes a toric surface model, and then the corneal thickness is calculated using swept source based OCT B-scan, and then the corneal thickness values are fitted onto a anterior surface, generating a toric model, and then using certain internal calculations, which they're not revealing as of now, they are able to assume and get the posterior surface of the cornea. The concept here compared to the previous keratometers is there is far lesser extrapolation, because this checks in more points compared to the previous generation optical biometers, but of course there is some extrapolation that happens. I feel that is the main reason why Barrett's calculator is slightly more accurate than the true K, because it involves some extrapolation, it measures the anterior surface and some calculations. Maybe with time this will evolve and give us much better results. However, as I said earlier, true K stands out and it is far more accurate, gives much better values when we use it for post-refractive surgery eyes. Now, courtesy Dr. Warren Hill, we understood or learned a new concept where he says with the Hill RBF, the true K is far more accurate. In fact, 95% of patients, if we use the true K on the Hill RBF, they are on track or less than 0.5 of residual refractive error for 95% of patients, which is a huge value. And the new kid on the block is the anterior SSOCT, where they say that the curvature from the anterior surface is measured using swept source based biometer and not using reflectivity. So there maybe in future this will negate the effect of the tear film on the cornea. However, it's too premature. We need to do some trials to find out evidence-based results for that. Now, comparison between the two biometers with regards to which is better, actually there's been some little bit of difference almost in all values in ACD, AQD, as well as axial length between the two devices. But what we have to learn is, we cannot take, suppose an institute has both instruments, we cannot take data from one and use it in the other equipment. Like for example, we cannot use a K value from the IOL 700 and put it with the Anterion, because they are based with different principles, they work with different principles. So interchangeable data should not be used. That is mainly because they have devised each keratometer maybe with slightly different refractive indices, and it measures at different areas of the cornea. However, with regards to IOL power, both the equipments gives more or less the same value, and the difference in power with regards to the final refraction has been hardly 0.03 or 0.12. We have IOLs only with one diopter difference. We have 21 and 22. I mean 21 and maybe 21.5. We don't have an IOL in between. So when there is an IOL power, say for example in one equipment 22 and in another equipment 22.25, we don't have a lens in between. So actually the results are not practically usable. Though they are statistically significant, they are not practically usable as on date. Future of K, they are talking of neural adaptation, or in other words, K which cannot be measured with the current topographers or with the biometers. They can be estimated by neural adaptation. Artificial intelligence to assess K may be the future. As I said earlier, K has been evolving. In 90s, we used the manual K. Then in late 90s, we believed that incision changes SIA. In 2020 onwards, we started talking of PCA. Then we spoke of centroid value for SIA. Now we are talking of predicted PCA. Maybe next conference, the concept may change. Evolution is the key. Change is only constant. Only the ability to change will determine our success in life. Thank you so much. We'll have discussion in the end. For the next talk, we did a survey in MCOA, and we found that about 70% of doctors even now are still using the ultrasound biometer and maybe getting fairly good results with it. To talk on that, we have Dr. Aditya Varman. He is a trainer and medical director at Umai Clinic. He obtained the prestigious CP Gupta Award at TNOA, youngster with a voracious appetite for publication and research. He will be talking to us on the role of ultrasound biometry in today's practice.
Hello and good morning. So today I'm here to talk about ultrasound biometry and its role in refractive cataract surgery practice today. So as we all know, accurate biometry is a cornerstone of any refractive cataract surgery. We have to absolutely nail all our biometric parameters to give the patient a good emmetropic result. So what are the main parameters we look at? We look at the axial length, AC depth, and lens thickness that any formula needs to give you an accurate biometry. The ultrasound biometer uses the ultrasonic waves to go ahead and give you the correct measurement of the axial length. So to understand it better, let's go back to the basics. So the ultrasound probe is a piezoelectric crystal that vibrates around 10 megahertz. It projects a thin beam of sound. This beam is either reflected, absorbed, or refracted. The beams which are going through and getting absorbed, part of them are also reflected back as echoes. These echoes will be detected by the transducer as waves or electric waves. And the more dissimilar the substance in the ocular anatomy, the stronger the reflection or the echo. So the measurement in the optical or ultrasonic biometers, usually from the anterior corneal surface to the internal limiting membrane. The accuracy of the ultrasonic biometers is about 0.1 mm between every reading. So a good ultrasonic biometric measurement has to give you these 5 waves. The first one will be when the probe meets the cornea. The second wave is from the anterior part of the lens capsule. The third wave is from the posterior pole. Then the fourth wave is from the retina, and the following waves are from the sclera and the orbital fat. So this is what an ideal A scan should look like. It should have good hyperechoic waves with the first wave coming from the probe, as I mentioned, and a good spike from the anterior lens capsule, and another good spike from the posterior lens capsule, and following the retinal spike, and then the scleral spikes. There should be no echoes in the vitreous cavity space. So there are 2 ways to go about your ultrasonic biometric measurements. One will be from the contact or applanation method, and the other is from the immersion method. So the contact method uses the ultrasound probe, which is directly placed on the anesthetized cornea. This is the most commonly used method in most places, but this has the drawback of indenting the cornea, which will give you a fairly shorter reading than the true measurement of the axial length. Whereas in an immersion scan, we use the shell known as a scleral shell or a Prager shell. We use a coupling fluid in front of the cornea, and once the shell is placed on top of the cornea, it is filled with BSS, and then you can use your probe to immerse the probe into the shell and get your reading. So this negates the effect of the corneal compression and gives you a more accurate measurement of the axial length and leading to more reproducible results. So this is your typical immersion A scan. You will see here, since the probe does not come in contact with the cornea, you have an extra wave coming from the probe, and then you can see a double spike coming from the anterior cornea and the posterior cornea, and following which you see the spike from the anterior lens and then the posterior lens. Then you see a line with the vitreous cavity, and then you have the spike from the retina and sclera. So immersion, as I said, works better and gives you more accurate results compared to applanation, but the drawbacks are it could be time consuming and messy, and you have to have the patient supine during the procedure. And after a single immersion biometry measurement, you do have chances of infection. There are studies which shows that organisms were grown from the shell and tubing of the immersion instruments. So what we do to counteract this is, after doing our measurements, we have to soak the immersion tube and the probe in hydrogen peroxide and alcohol for at least 5 minutes. And it should be allowed to completely dry and should be flushed with balanced salt solution. So what are the cornerstones of an accurate A-scan measurement? One, the machine should be correctly calibrated. We should ensure that the patient is in the correct position. The probe must be absolutely perpendicular to the iris plane, and there should be minimal corneal compression. It would be ideal to do the A-scan with the patient in the lying down position and never the patient sitting down. So this is an example of incorrect positioning. As we see here, the patient is lying down with the head at an angle. This is bound to give you errors because the angle of incidence at which you place your A-scan can be inappropriate. You will not be going at the anatomical visual axis. So this is the example of an correct head positioning. As we see here, the head is absolutely flat. Iris will be parallel to the floor. And now when you go ahead and place your probe perpendicular to the iris, you will get a good axial length measurement. So as I said earlier, the idea is to avoid corneal compression. The iris has to be parallel to the floor with the probe perpendicular to the plane. When the corneal beam is parallel to the visual axis, the returning echoes received back to the probe will result in a high amplitude spikes, is what we like to see in a good A-scan measurement. So fixation can be helped by giving the patient a target to fix at. You can use a patient's hand, or you can use an overhead fixation target, or you can simply ask the patient to look at the fixation light in the A-scan probe. So here is an example of a good A-scan measurement where the patient's head is parallel to the floor and the iris is parallel, and the patient is looking up at his own thumb to fixate, and the probe is being held by the wire to avoid the chance of any corneal compression effect. So this is the fixation light the patient can be asked to look at to go ahead and enhance the patient cooperation. It is also ideal to wet the probe before going ahead with any A-scan measurement, because measuring on a dry cornea can also give rise to a fallacy in the results. Also, so here is an example of an corneal compression happening, because when you hold the probe with your fingers, you do have a chance of indenting the cornea unknowingly. Whereas if you hold it by the wire, the chances of corneal indentation is greatly reduced, and you give a more accurate axial length measurement with the A-scan. So again, this is a very typical A-scan, which is a good measurement. We see the high amplitude spikes, and all the 5 spikes are very well seen here. And make at least 2 measurements. Multiple measurements are more ideal. And a 0.5 mm measurement the variation between 2 readings is acceptable, but one should aim for at least a 0.2 mm variation between multiple readings. Yeah. So when you're not getting the correct waves in cases of a dense cataract or any other opacity, it would be ideal to increase the gain. So the height of the echoes will be adequate in a denser cataract. A decrease in gain is required when you have other artifacts in the interface of the vitreous, such as in silicone eyes or any other vitreous pathology. But one should be aware that a high gain can give rise to a shorter axial length reading, whereas a low gain can give rise to a longer reading. These are the sound velocities that have to be modified for different cases. For aphakia, make sure that you are selecting the aphakia mode, and for silicone oil, do select silicone oil mode. Another important thing when you're doing an immersion biometric scan is to select the immersion mode on a biometer, and also take multiple readings, and every reading check the waveform in every A-scan. Choose the best and the most consistent one. Do not take an average of all the readings. If you're taking 5 readings and if 2 readings are way out of bounds, it will be better to eliminate those 2 readings which are out of bounds and take an average of the 3 readings which are all similar to each other with the same axial length. So here is an example of multiple readings being done. So as we see here, on all the readings, the axial lengths are quite similar to each other. It would be prudent to take the first scan here, as this scan has the best waves. So this is the ideal scan with which the waves are all of high amplitude. This is the scan which we would take in all our axial length readings. So, and ensure that all your other steps are on point, or otherwise you can have a stacking effect and give you an erroneously wrong formula. Make sure that your K values are all consistent, and make sure that your A constants are also on point. Otherwise, the IOL power that you will have between 2 readings can be grossly wrong. So here are the pearls. Calibrate the instrument, use immersion method, make sure the iris is parallel to the probe. The probe should be perpendicular to the iris plane. Ensure patient fixation, check all the waveforms, and hold the probe with the wire while doing the contact method, and do not take an average of all the readings. So the drawbacks are, it measures from the anterior to the posterior pole. So it only measures the anatomic axial length and not the optical or visual axial length. It also only measures up to the internal limiting membrane. It does miss out 200 microns of the retinal thickness. So you can have an error here. So the causes of an erroneously short measurement can be corneal indentation, low sound velocity, too high of a gain, or a malalignment of the probe. And erroneously wrong long measurement can happen when there's a rapid sound velocity, too low of a gain, or a posterior staphyloma. So the potential of error is more in a shorter eye, but is more forgiving in a longer eye. So can A scan give you precise results? There are multiple studies and publications out there that are proving that A scan is as good as an optical biometer when done correctly, when you take all the appropriate steps as mentioned above. You can give a good result with a very low post-operative residual outcome, as long as you follow all these preceding measurements. And it should not really deter you from going ahead and giving your patient a premium experience and with a premium IOL result. So an A scan with a good technical skills can give you good results at the end of the day. Thank you.
So much, Adit, for a wonderful presentation. You've covered everything on A-scan. Well, for the next talk on why optical biometry, we have the best in the business for you. He's been using SSOCT-based optical biometers ever since it was launched. He's given this talk in ACRS APAO, well appreciated. I take pride in inviting my mentor and guru, Arun Mulivarman sir, to talk on why optical biometry.
Thank you, Atheek. Good morning. My talk is on why optical biometry. You put it in one single small little phrase or a sentence, as we can say, for very, very predictable outcomes. But let me put up this caveat that yes, you can get excellent results even with ultrasound biometry if done properly. How does the optical biometer score over the ultrasound biometer? Because it can be delegated. You can delegate it to a person who is not fully trained, who is not very experienced, and still get great results. Well, on the other hand, if you're doing ultrasound biometry, it should be done by a person who is highly experienced with a lot of knowledge and skill. Again, most important, biometry does not mean only the axial length anymore. We want to know not only the axial length, you want to know the corneal curvature, you want to know the depth of the anterior chamber, you want to know the lens thickness. Because eventually all of these factors come into play to tell you where the lens is going to sit after you implanted it, or the ELP or the effective lens position. We also now need to know the white to white. All of these calculations need to come into play for you to get excellent results. So you can get all of these results independently when you're using an ultrasound biometer. You can measure the white to white with a caliper or some other instrument. Then you can do, of course, you can get the corneal thickness from a different factometer. Then you can get the anterior chamber depth from the ultrasound. Yes, from the lens thickness also you can. But the advantage of doing optical biometry is that all of these readings, starting from white to white, to lens thickness, to the anterior chamber depth and the axial length, everything comes to you in one go. So that way it scores over immersion A-scan, because all come out of one single button push and from one single source. What is the ultimate device that you can use today as an optical biometer? We've had several models that have come over the last 15 or 20 years. The one that is most appropriate today would be the SSOCT-based optical biometer for the following reasons. So axial length alone does not suffice. As I told you, you need axial length, ACD, CCT, white to white, lens thickness, K values also. When we talk about K values, what Atheek had mentioned, that we normally get only the anterior K from a keratometer. We need to get the posterior K, and you need to know the posterior refraction also, as well as the true K, to get the best out of the new formulae that we are all using. SSOCT-based optical biometers can give all of these together. The one that I'm familiar with is the IOL Master 700. There are several other models available which probably are equally good. So what is it that you can get from all of this? I can get the axial length, anterior chamber depth, lens thickness, central corneal thickness, white to white, pupillometry, keratometry, and we can also get the reference image to use it on the Callisto markerless system to make your surgery more accurate. Keratometry plays a very, very important part, as Dr. Atheek told us. You can go wrong on axial length by even up to 0.2 mm and get very minimal variations in refractive outcome. But the same amount of error on K values can give you a huge amount of refractive surprise. To get a proper K value is paramount. We most often neglect that. and put all emphasis on axial length. So the K values are taken off from some other instrument that is not calibrated, done by somebody who is not really experienced, and they just noted down. If importance is given to K values from the start to finish, even with the manual keratometers, you can get excellent results. What is the advantage in using an optical biometer? It does give you better results on K values than any manual keratometer, since this looks at different zones. Depending on which machine you're using, it can look at a zone from 1.5 millimeters right up to 3.6 millimeters. So you get a true K value, which is very, very accurate. SSOCT-based optical biometers can also do a scan of the cornea and look at the posterior corneal curvature and know the posterior corneal curvature also. Since you get both of these parameters and values, the machine can calculate true K, which is very important for some of the more advanced formulae that we use. So you get posterior K, true K, and now with this SSOCT-based instruments, you can also get a central 3 millimeters or 3.5 millimeters, a central topography. This topography is not going to replace a proper corneal topography that you can do if you wish to look at the corneal topography. But this does tell you the central 3 to 3.5 millimeters is very critical, whether there is any kind of a severe asymmetry, which will probably give rise to problems, and this patient may not be even fit for a proper toric lens. Or it can give you an alarm that this person needs a toric lens. So central topography also comes in useful. So this is how he looks at it. He looks at the anterior and posterior in three different zones, which are staggered, so you don't miss out any point of the cornea, and you get very, very accurate results. You look at this, zone 1, 2, and 3, and these points are staggered. So you really don't have any areas where the corneal curvature will not be measured. It can look at both anterior the same way, the posterior, and then give you the true K. Central corneal topography, as I told you, it's a small area, but does tell you whether the topography in the center is regular, irregular, or highly irregular. So for all of these, you don't need a second instrument. That is a basic issue here. It's one push, one button, and all these parameters come into your screen. Often we have transcription errors. Somebody takes K value from one source, the axial length from a different source, white to white from a different source. They're all noted down on a K sheet. Then they've entered into the formula as we go. Transcription errors also tend to come in sometimes. So when you have this kind of an instrument, transcription errors do not come in because data is taken directly in and it's taken and dumped into the formula and calculation is done. One other chance of error is also negated. Since you have an OCT scan that goes from the anterior cornea to the lens right up to the retina, you can actually look at the retinal foveal pit and recognize it and know that your axial length is measured through the foveal pit. It can also help you to find out if if you're not on the foveal pit, so you know this particular reading can be taken away. Third, you can actually find out very subtle changes at the fovea. This machine does not replace the proper OCT to find out pathologies on the retina, but as you do the OCT, the axial length measurement, you can see the retina clearly enough to find out any kind of an obvious macular or a foveal disorder that will alert you to the fact that this person may not get clear vision, or alert you to the fact that you need to do further tests before you take this person up for surgery. So you can catch these kind of images on the OCT. Contrary to popular belief, the new optical biometers can penetrate through even very dense mature cataracts such as these. This is a true picture on a dense mature cataract such as this. You will get excellent results. So now it becomes very, very applicable even to patients who are with a very, very dense cataract. And all of these machines come with the latest software. So as of today, I would suggest that we go on to Barrett Universal 2 and do the calculation. It will be better than even using what's on the machine to use what's available on the website. It's available on the APACR's website, so you can get the more updated software available anytime, and it's free. So do use Barrett Universal 2 for all your calculations. So you can start off from one point to another seamlessly and get the best results. So it's just one surgery, quick surgery to show you the markerless suite. Why is it not playing? I checked it out there. He did, it played. No, he just played it. He played it just now. No? Yeah. Okay, forget it. No, I don't have the folder here.
Movie is embedded in the PowerPoint. Okay. You have a thumbnail which you can plug it in now.
Yes, it is.
And the video has not got transferred.
We checked it. Or...
You collapse the later.
No, let's hold on. We're wasting time. Okay. Computer.
So, you include
Yeah,
the
this one?
sun or
Yes, big right, yeah. Okay.
Go down again. Scroll down. Yeah, okay.
I
No,
have
it's
no
playing something
financial
else.
interests regarding this video. Why do refractive surgeons avoid
Why optical
refractive
biometry?
keratectomy?
That's what I clicked on.
Owing to the postoperative epithelial defect,
Why optical biometry? Okay. So I look at that. So you have this ability when you use an optical biometer, you can transfer the images to the microscope. Will tell you where to do the rexus, where to do the incision. So you get a perfect incision. So if you're using a toric lens, you get the marker that tells you the axis on which to place the toric lens. This data comes off from the keratometer of the optical biometer and is projected internally for the surgeon to see during the surgery, and of course comes on the video too. So when you eventually position the lens, the accuracy that you achieve in the positioning of the lens is far more than you would ever achieve with a manual system. You can see that there, a perfect positioning again. So advantages in using an optical biometer: 1, high accuracy; 2, multiple readings coming out from one source; 3, no transcription errors. It can be delegated. 4, if you have the appropriate software and instruments, you can have a markerless system which makes your surgery even more accurate. So to end up, what I would say that optical biometer, what was thought of about 2 decades ago as a kind of a luxury, is not truly a luxury anymore. It is something like a necessary tool. There are different ones available. If somebody is thinking of going into optical biometry purchase, do not go in for the older versions. Please choose the SSOCT-based systems. There are several available on the market. Thank you.
Thank you so much, sir. So just one quick question. You've been using this equipment for quite some time. Do you use TrueK for your cases, or do you prefer using Barrett's PCA, sir?
I still go with the Barrett PCA.
Okay, sir.
So I don't use the TrueK, but it's available.
Okay.
So as the formulae keep evolving, TrueK will become necessary sooner or later.
Okay, sir. Thank you, sir. So almost every year we hear new formulas coming up. To talk on new formulas, we have an encyclopedia in biometry. Ramesh, sir. Welcome, sir.
Thank you. So regarding the true K measures the front and the back, and then it calculates the actual true K of the cornea. It is found to be most useful when used in patients where you have a dissonance between the front and the back, like in ectatic eyes and thin corneas, and in keratoconus and post-LASIK eyes. For the normal, regular eyes, still the standard anterior K is fine. So my talk today, thanks Atheek, you asked me to talk about Barrett's and Kane formula, and excellent. We all heard about David Chang, former president ACRS's comment that true happiness will be there for the patient when he gets 6 in any one eye. Can you just put your hands up? How many of us are using SRK2 formula? Yes. Thank you. So for over 25, 30 years, I've also used SRK2 formula, and most of us have. SRK2 formula, SRKT are great for the majority of the eyes which have a normal anterior segment and a normal axial length range. But we do have eyes like in the extreme zones. We have buphthalamus, nanophthalmos, microcornea, axial hyperopia, extreme eyes where a two variable formula like SRK2 or T is not enough. Norsby's seminal study showed that errors in calculations come from three sources. A third of the error is because of calculation error. A third is because of measurement error. We measure an inaccurate K or an inaccurate axial length. And one third is actually a result of refraction. Refraction lane length is not correct. The refractionist is pushing too much minus or plus. Now we are today concentrating on the IOL formula error and how to reduce this particular component. Before 2010, most of us, the elder, senior, older ophthalmologists were using half a Q for small eyes, SRKT for longer eyes. This was what we were all doing. After 2010, we started using Barrett's Universal 2 group of formulas, and we are very, very happy, and we all felt that we were on top of the game. After 2010, in the last several years, Barrett's 2, along with EVO or Hyperopia verifying optical formula, the Kane, Nasser, Olsen 2, Panacea, Pearl DGS, the RBF of Warren Hill, T2, and VRF, and other formulas have come in, trying to plug the gap and make it more possible to get better results with extreme eyes. Publications show that only 50 to 70% of our patients are within half a diopter of Hyperopia with the older formula. And with the newer formula, 70 to 80% of our patients are within half a diopter of Hyperopia. We saw that for a normal average eye, where you're putting an intraocular lens of between, let us say, 20 and 22, any formula will do well. But if you have a short eye, if you have a microcornea, if you have unusual eyes, the old two variable formulas are not enough. Let us see what has happened in 2017. 2010 to 2017, all of us who are using Barrett's Universal 2 became very happy when this particular review article of 18,000 and all patients by Ronald Mellis et al. Came out. Jack Holliday was a co-author of this paper, and the conclusion was overall Barrett's Universal 2 gave the lowest prediction error. So we're all very happy. We're using Barrett's, we're using the best. This is one of the pictures from within the presentation. This is the mean variable, and this is the 0.25 error. If on the left and right, you can see various lines, the blue line, the yellow line. Those are all the different formulas which were used to this group of 18,000 patients, which are all post-op. We knew the pre-op values, we know the post-op outcome. And we can see that in all of them, that the central zone, any formula works. In the extreme zone, most formulas don't work. There is a big variability in outcome when you have a IOL power of plus 10 or a plus 30. So extreme IOL powers, none of these formulas work well. In 2019, the same group, Ronald Bellis, this time with Kane and Thomas Olsen, again redid the calculations, and this time he came to the conclusion that overall, Kane formula was the most accurate with 83.1% of eyes within 0.05 diopter of predicted outcome. So Kane is slightly better than Barrett's overall. Here we can see two blue circles. The circle on the right circles Holiday, SRKT, and Hofeq, the older generation of formula. The circle on the left covers Kane, Olsen, and Barrett's U2. So you can see there is a 10 to 15% increase in accuracy with the same measurement if you just shift your formula to Barrett's Universal 2 or Kane. Olsen is still now a paid formula, so most of us are not using it. In 2020, there is a nice review article by Savini et al. Please go through that. It describes all the modern formulas, how they work, and how well they are doing. What has happened in the last 2 years during the COVID time? Here is a nice review article comparing the accuracy of several formulas for eyes with extreme axial myopia, that is more than 29 millimeters and more than 31 millimeters. So on the left, you have extreme myopia more than 29. On the center, you have extreme myopia axial length more than 31. And if you see, some of the best are Evo, Kane, Olsen, and Barrett's. So these two are still far better than SRKT and Haigis. I hope this presentation pushes you to stop using SRKT and Haigis for these very long axial myopia eyes and start using Kane, Evo, Olsen, and Barrett's Universal 2. One more concept has come up recently where you call it segmentation of formula. If your axial length is 29, please use Kane. If your axial length is 31, please use something else. If your axial length is less than this, so different segments of the axial length need different formulas for the best outcome. So this 2022 review in January showed that Kane formula had a mean prediction error close to 0 for high myopia. Session ends in 10 minutes. Thank you, Ma. We'll finish in time. So Kane is better, especially when you have very long eyes. This is an example of one of my patients which I implanted 4 days ago. Kane says put a plus 15, while Barrett's Universal 2 gives a plus 0.50. So Kane pushes you to the next higher power. Mean prediction error is closer to 0 in high myopia. This is one take home. Let us come to the hyperopic end of the spectrum where the IOL powers are like 25, 26, 30 and above. Here is a very interesting 2022 comparison. This review article reviewed several studies, 14 studies with 1,475 eyes. Very difficult to get 1,475 short eyes. And the conclusion was the Pearl DGS had the highest percentage of eyes within 0.25 error. What is a Pearl DGS? It's an artificial intelligence-based open source formula. It's the formula code is available online, unlike most of the other modern formulas. And we're all familiar with Gataniel. He has done a lot of work on the cornea from Paris. So he and his co-workers have got the Pearl DGS formula. So in conclusion, in extremes of axial length and corneal measurement, please think of using Kane for high myopia. Consider Pearl DGS for very short eyes. Think of Evo and Hill RBF. Hill RBF gives you the boundary zones and tells you whether your formula is correct or just guessing. And we can all expect incremental progressive improvement in the current generation of formula, which use regression analysis and artificial intelligence to improve themselves. Thank you.
Thank you so much, sir. So my take home is, today I've learned that there's a new formula called Pearl DGS. One formula fits all is not the key. Customization can be done and has to be done. Thank you, sir. So the next talk on complex biometry, we have our go-to guy. Any complex scenario, Jayantan can give evidence-based advice on it. He's a pediatric ophthalmologist and refractive surgeon. Over to you, Jayantan.
Thank you, Atheek. Pleasant morning to everyone. Okay, whenever you have an issue with any of these pillars of your IOL power calculation, that makes your situation more special. We'll start with the keratometry. So to remember, if your Myers are not crisp and clean, the validity of all your other measurements are going to be diminished. May it be a manual keratometer, automated keratometer, or an optical biometer. Let's see one example. This is a LensStar image. Instead of just going ahead with your blank values, always do check your image quality and the standard deviation. If the image quality is not good and your standard deviation is way ahead, always discard these values, treat the patient for ocular surface disorders, get them back for remeasurement, and then go ahead with your calculation. Next is the keratoconus. the keratometry in keratoconus is going to be inconsistent. When I mean inconsistent, it says different instrument is going to give you different values, and within a machine, you're going to have a less of repeatability. All this is because of the irregular astigmatism that is present. An unusual anterior chamber depth will lead to an erroneous ELP calculation that will lead to a wrong IOL power calculation. The visual axis is not on the apex but on the cone, and always remember the keratoconus creates a negative spherical aberration which is going to affect your IOL calculation. So once you have the keratometry values, it is always better to recheck with your tomography. The main advantage of tomography is that it will give the health of your posterior cornea, it will give the health of your anterior cornea right from the center to the periphery, and of course you can grade the keratoconus with the tomographers. Never use a SIM-K value. Axial length preferable to be used from the optical biometers. So once you have the K and the axial length, for a mild to moderate keratoconus, it is better to use a SRK-T formula or a Barrett Universal 2 formula. For a severe keratoconus, definitely choice of IOL is going to be very difficult. It has to be based on case-by-case basis. Issue with axial length evaluation will start from the higher axial length. In eyes with an axial length more than 30 millimeters, a posterior pole cephaloma temporal to the fovea was quite common. The cause of error in these cases is mainly because of the irregular shape of the ocular wall. Remember, the deepest portion of the cephaloma may be located eccentric to the macula. When it comes to an ultrasound, if at all if it is a contact ultrasound, remember these eyes will have a low scleral rigidity and the chance of indentation is going to be very high. There will be an inability to display a distinct high retinal spike, and these ultrasounds will give only the anatomical axial length rather than the refractive axial length, resulting in IOL power that is going to be too low. So the solution is to use a vector A-B scan, do a B scan, locate the fovea, and then do an axial length measurement using the A scan. It can be used to demonstrate the shape of the posterior ocular wall and relationship of the macula to cephaloma as well. If at all, if it is an ultrasound, it has to be an immersion, and a probe with the fixation light is preferable in these patients. The best of it is to use an optical biometer, especially an IOL Master 700, which measures the axial length by directly visualizing the fovea on the OCT image during the measurement. So once you have the axial length measured, a cephaloma is like any of the high axial myopias. So coming to the formula, traditionally in SRK-T is used. A fourth generation formula of Barrett 2 has the best predictive value in the myopic eyes and the lower IOL power. Let's see what we have in the literature. This article in 2019, when we had the last face-to-face conference in 2020, it was concluded that Hill RBF and Barrett were more precise than Haggis, Hoffer, Holliday, and the SRK-T in myopia. But the Hill RBF was independent of the axial length. But recently, now in 2022, the JCRS article concludes saying that the best overall results were noted with the Barrett True Axial Length formula, EVO, Hoffer QST, K6, Olsen, and Pearl DGS formulas, closely followed by the Barrett. So Barrett once, which was thought to be the universal, is actually becoming followed by Barrett formula. Right. So coming to the extreme hyperopia, the issue is that you have an altered anatomy, and if you're going to use a mean sound velocity and an automatic biometry mode, either you won't get the values or it will be erroneous. These eyes will have a highly magnified error. For example, a single millimeter change of axial length from 20 to 19 will produce a 5 diopters of change in the IOL power. This small shift in ELP leads to a bigger surprise. The main reason is the lens is thicker and is very closer to the fovea. So if at all, if it is an ultrasound, it has to be an immersion to reduce the indentation. So in a semi-automatic mode, with the corneal double peak echo clearly discernible, all the other 4 ocular landmark echoes may be adjusted for the optimal steepness, thus achieving the best orientation. It's always better to use an optical biometer and use a formula that calculates ELP from multiple parameters. Ultrasound, go for an Hoffer Q. Optical, better to use a Barrett Universal 2. And if the ACD is less than 2.4 mm, use a Haggis formula. If you have an edema or a tumor sitting on the macula, it is going to affect the outcome of your calculation because it prevents the display of distant retinal spike and causes a shortened axial length. If the patient has got a dense cataract and you don't have an access to optical biometer, there are certain markers in which you can identify these. They are like unexplained spikes along the vitreous base, inability to display a distinct high retinal spike, abnormal separation of the retinal spike from the scleral spikes, an inconsistent axial measurement of more than 0.2 millimeter, an inter-eye variation of more than 0.3 millimeters. Astrohyalosis, vitreous hemorrhage, gas, needs a high gain setting in ultrasound mode to obtain spikes of sufficient height. In silicon oil filled eyes, the source of error is mainly because of the low sound velocity, leading to an apparent noise attenuation and difficulty of identifying the retinal spike. Basically, silicon oil changes optics of eye due to its refractive index. So an ultrasound travels slowly in the silicon oil. This has been perceived by the probe as a longer axial length, which gives a lower IOL power. Usage of a standard sound velocity can give an error of up to 8 millimeters. So the simple solution is to use a correction factor of 0.72, which will give a rough estimate of the power. The best is to use an optical biometer because the change in refractive index is less affected in case of an optical biometer. Denser cataracts, where the optical biometer doesn't work, use a maximum gain setting to obtain the spike of sufficient height, and you can use a semi-automatic mode. This situation will be complicated if the patient has got a poor fixation due to low vision, nystagmus, blepharospasm, or strabismus, which could be handled by blocking the patient and then redoing the calculation. Piggyback IOLs depends whether it is a primary or secondary. If it's a primary, use a Haigis or a Hofferke formula, arrive at the IOL power, divide the power into two IOLs, a single piece IOL, single piece hydrophobic IOL goes into the bag with full power, and three-piece hydrophobic IOL goes into the sulcus with one power reduced. If it's a secondary IOL, it has to be only based on the refractive error. No knowledge of the primary implant or an axial length is required. Use a Holliday's refractive formula or a Barrett RX formula. The issues with calculation, the main situation here is a post-refractive eyes. The reason why we have inaccuracy is that we have a keratometric index error, radius, and the formula error. In keratometric index error, generally in calculation, you use a refractive index of 1.3375, which is actually a fictitious one because it assumes the anterior and posterior cornea to have a specific ratio. It works well in virgin eyes, but when it comes to a post-refractive eye, where the anterior cornea is actually altered, the ratio of anterior to posterior is also altered, so the ratio becomes invalid. So in case if you're going to use this in a myopic correction, it will overestimate the K, underestimate the IOL power, resulting in a postoperative hyperopia. Higher the attempted correction, higher will be the over or the under correction. So the solution is to use a technology that measures both the curvature, either using a sheen plug imaging or an OCT-based system. Next is the radius error, where an instrument extrapolates the central cornea from the paracentral measurements. Imagine the central cornea is already flattened and the paracentral cornea is going to be steeper, so the K will be overestimated. This is more relevant in eyes with smaller optical zones and decenter aberration, which was very common in the older generation machines. So use the central values from the tomographer rather than a SIMK value. Formula error, remember the keratometry is at fault. So when you're going to use the keratometry for the ELP calculation, all these formulas are going to be erroneous. So in a myopic ablation, it's going to end up in an undercorrection of the IOL. So the solution is to use a formula which doesn't use a K for its calculation, and any other parameters used for ELP could be used. One such formula is a Haigis, which is already incorporated in IOL master, or it's better to go for a double K method. Depending on the preoperative refraction and the keratometry, you can go for the preferred double K method. In case if the patient doesn't have a preoperative data, or if it is unreliable, which is going to be the most common cause in our cases, you can go for the older technique of Shamas and Maloney's method, which is there even in the older generation optical biometers. But the current concept is to use a Barrett True K or a Haigis L. And the look forward future is going to be a Gaussian optic formula and the corneal ray tracing phenomenon, which uses a Snell's law. This is a Barrett True K formula, which is incorporated in ACRS, APSRS online calculators, feed through use calculator. Whatever possible measurements you are able to take in your clinic, just input and get the values. It's a small case wherein, this post-refractive patient, actually we did a lens star calculation and an ARSS calculation. You can see that both the Shamas and the Barrett True K value was absolutely corresponding both for both the calculation. So to conclude, remember there is no one-size-fits-all calculation method for all these cases. Understand the science of IOL calculation, keep validating your measurements once in a while, stay informed about the latest development, and most of it, don't remove yourself from the process. Don't let it go through an optometrist. Keep involved, especially when it comes to such a special situation. Thank you.
Thank you so much, Jayanthan. I thank all our speakers, Aditreya, Arul sir, Ramesh sir, for this wonderful session. And thank you so much. Thanks AOI Scientific Committee and Partha sir for this amazing opportunity.